We're live.
It is November 4th, 2021. I'm Dr. Ara Deukmedjian, CEO and founder of Deuk Spine Institute. We're getting ready to start a Deuk laser disc repair procedure to help a patient with, we always start lateral. Always start lateral. To help a patient who has 2 herniated discs in his lower back. Now, how long have you had pain in your back? 6 years? 7 years? 8 years, sorry, 8 years. All right, 8 years. And we're going to fix that today. I want to try to get our blood pressure down a little bit. Let me know when you're able to bring it down just a little more. Lay still, you're fine. All right, I need to see the back a little more. So the first thing we're going to do in this surgery is access 2 discs. You see the double pedicle at L5? I don't want to see a double pedicle. Go ahead. Take a shot. It's not an orbital issue. It's a WAG issue. Double pedicles are always WAG. So folks, what we're doing here is we're getting our navigational instrument lined up. I would move south if I were you. I think your pedicle is fixed, but you'll probably have to make an adjustment. You want to be centered at basically 4-5-5-1. That's pretty good in terms of, I think you're off orbitally now, and your WAG is off again. So we're lining up our navigational instrument to the patient's body to gain accurate information about where we are in space. I don't know what to tell you except your L5-S1 is at the bottom of the screen. I need it in the middle of the screen. So you're going to have to move your entire base south. That's better. Now you fix the WAG. You can see the pedicles are off. So figure it out. It's either one way or the other. I want to say, Luis, what do you think? Worse or better? What do you think? The other way? You want to try? That's fine. You're a little bit off orbitally as well. Maybe he's got some scoliosis. That's why we're seeing that. Your orbit's off just a tiny, maybe a degree at most. All right. So you're happy with that? Yeah. I still think we're off a little bit. Do the orbit. See the double shadow in the back of the pedicle of 5? Yeah, try that. That's better. So, yeah, there's definitely some scoliosis. That's what we're dealing with. I think that's probably the best we're going to get right there. How's blood pressure? Better?
It's coming down.
All right. So, I like the blood pressure to be... Huh. Usually around 120 or less. No, that's all right. Take your time. I'm perfectly fine waiting to get it right. So Monica, is there any way to zoom in more? I want to see that level better, L5-S1. Yeah, that's what you're going to need to do then.
Thank you.
All right. So that's better. Yeah. I don't need to see the front so much, so you can either drop the table, raise the fluoro. You can do that too, but I need to see the back. That's good. All right. Okay, so again, I think we're seeing too much sacrum now. A little bit too much sacrum. Yeah, it's better. Now, if you're looking at this x-ray like I am, you're thinking, it's not perfect at 5-1. Oh, God, I don't know what you're doing. Give me more in the back. I got to see where the needle's coming in. It's not enough. You're going to have to open that up in the back. I don't know. Are you all the way in?
Yep.
You're up against the bed?
Yep. Not coming any further.
All right. I need to see kind of a little more of the needle.
A little more where?
Needle. You know we're putting a needle in, right? A needle is long and straight. So you have to see where it's coming way before it gets to the disc. There we go. That's better, but still a little too much sacrum. A little too much sacrum. A little too much sacrum. I know it's been a while. Don't make me call Jordan in. All right. That's better. That is better. All right, so I'm thinking this fucking lidocaine is worthless. Try not to move. You're doing really good. When you move, you change my alignment of everything. So you're doing good. Everything's okay. All right, we're getting there. Let me know if you feel some discomfort, okay? Can we clean that up? I don't know what's happened. He's moved a little bit. Monica, you've got to respond. I can't have him move to reposition. You have to reposition the fluoro when he moves. Where do you feel that, Sean? Huh? In your back. Yeah.
He looks like he's rotated.
Oh, yeah, he's... Him?
He does, yeah.
Yeah, he's... For sure he's got some scoliosis. There's no doubt about it. You're fine. Just hang in there. Shot. Shot. The trajectory looks pretty good. I got to get that end plate of 5 lined up. You know what I mean? Try not to move. You're doing really good. Can you give me a better end plate of 5? It's going to be a wag issue. I think you're going the wrong way. Oh my. Alright. That is a little bit better. And we're off. No, it's too much. Shot. Yeah, that's better right there. Alright. Let's just leave that. Okay. Shot. It's a little higher than I want to be. All right, let me have the wag. Shot. 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 That's good right there. You move south too much, I think. Shot. What just came off over there? Something came off over there. Shot.
Check the Y2.
Shot. Sorry? Shot. Where do you feel that?
Left.
He didn't say leg, right?
Left.
Not down your leg. I understand. You're doing great. Just hang in there, Sean. I think we're up against, yeah. Sean? I think he's moved just a little bit again, but I think might be okay. Shot. Give me an AP. You all right? No, I have to check the AP first. We could be deflected. I got to make sure we're not deflected. If we're deflected, I have to redo it. So, hard to say. I think we're a little deflected. Huh? Yeah, go back to a lateral. Oh, by the way, for those of you watching, L5-S1 which is what we're trying to access, is always the hardest disc to fix. So it's very common to struggle a little bit at L5-S1. All right, as far as the X-ray looks, I think we're pretty good. In terms of the end plate of 5, end plate of S1, pedicle 5, facet complex of 5-1. I'm just not happy that we're not more centered. I wish the base was a little more north. Yeah. All right. Again, we've lost it, our view. We just keep. We're like a monkey trying to screw a rolling donut, chasing it around. Yeah, but it's your job to get it right. That's what I'm trying to say. Now I can guide you, but ultimately I got to worry about what I'm doing. You got to get me the right picture. So I don't think that's too. Again, you just swung down south. You're showing me too much sacrum, not enough of 4. What happens when you get too much hip? Huh? No, you get too much hip, you use too much X-ray radiation. You have to boost to get through all that soft tissue and hips. So you really should be, that 5-1 disc should be in the bottom half of the screen. I shouldn't be wasting 10 minutes trying to get the X-ray right. That's exactly where it should be. Now you just got to get the pedicles lined up and the end plates lined up. And that actually, it looks pretty good. I just a little blurry because I think there's some movement. No, that's pretty darn good. I think that's pretty darn good. All right, let's try to keep it there. How are you doing? I'm going to do a little dye just to see if we're inside the disc or not. Okay, if we're in the disc, we're going to stay. If we're not in the disc, we're going to reposition. Shot? Let's go with an AP. Come back to that same lateral. Give it to me. Oh, wow. So we are in the disc. All right. I'm a little surprised, but hey, I'll take it. Huh? No. I just want to make completely sure. 1000%. Is it pretty collapsed disc? Yeah. Shot? It's kind of open for the AP, but that's fine. Shot? What do you mean trying? All right. Are you comfy? All right. We've got the harder, I think the harder disc already done. So that's the good news. All right, we're starting on the not as hard disc. So I apologize, it's taking us a while, but everybody's anatomy is different. So, you know, some people are easier to access the disc, other people are harder. You're one of those a bit harder. Blood pressure is still good, yeah. Shot, good. I need to see behind 4-5 a little bit, but otherwise it looks good. Anything you can give him for some anxiety or settle him down, he's like, as soon as he feels a little inkle of pain, he's jumping off the table like a mullet. Shot. All right. Just a little bit of something. Something that wears off quickly. Shot. Honestly can't see. What's happening there, Jordan? Let's get those pedicles lined up at L4. Yeah, that's a little better. We're almost perfect. Yeah, that's good. That's really good. I like that. All right. Shot. So clearly I'm encountering the facet joint, which is normal to get right here. Shot. And I'm trying to get around it, which is normal to get around it. Shot. But I don't know if he's so rotated or what. Let's get an AP. I have a feeling I'm going to be more medial than I want to be. I'm just going to apply some pressure. Blood pressure still 116. Let me know before you take the shot. Go ahead. Yeah, so I'm a little medial. All right. Come back to a lateral. That's perfect. Everything's going good. You have nothing to worry about, okay? Let me know when you're ready. And you're pulsing, right?
Yes, sir.
Go ahead.
Take a shot.
All right, so that's good. We're almost done, all right? I promise you. You're very close. Shot. Where do you feel that? Huh? In your back? I need you to help me, doctor.
In his back.
Yeah, perfect. Shot. Shot. Still in your back? Nothing down the leg, right? Shot. You comfy?
Great stuff.
All right. We're going to be putting you to sleep soon, okay? I just need your help for a little bit longer. Are you comfortable? Shot. How bad is that on a scale of 1 to 10?
10.
Is that where you typically get back pain? All right, we found one of your bad discs. Move your hand, please. All right, so that was the L5-S1. 10 out of 10, typical pain, concordant. So L5-S1, 10 over 10. Is it better now? All right. We're going to be putting you to sleep very soon. Just not quite yet. How bad is that? Look at the size of the tear. Show them the tear, please, Jordan. Look at the tear at L4-5. It's massive. How bad is that on a scale of 1 to 10? I can't hear you. 8. Is that where you typically get your pain? So Jordan is showing you with the arrow where the herniation is and where the tear. Show him the herniation. That's the white arrow. Show him the tear. Yep, that's the tear. From there all the way to the right. Go to the right. There. From there to there, that's the tear. All that's the tear. So we had an 8/10 in pain at L4-5. You get to go to sleep. When you wake up, we'll be done with your surgery. You want to do 5-1 first or 4-5 first? Can you count from 1 to 100 out loud? Count out loud? Nice and loud. Shot? We're going to do 4-5 first, per Luisa's request. Shot? Can see the guide wire on the lateral x-ray. I'm going to use the guide wire to direct my dilator. You can see this, Diego?
Yes, I can see it.
It's going to slide right down this guide wire. Guide wires have been used in spine surgery for years. Even when I was in training, we were using guide wires. Back in the early 2000s, we were using them at that time to put in screws. Shot? What were called percutaneous pedicle screws. It was a newer technology. And we were basically running the screw right down the guide wire. Shot. So the first disc we're going to fix is the L4-5. You see the dilator is heading right for it. Shot. All right. And here we are. Now there's a massive tear in the back of this disc. It is huge. We're going to go into that tear and we're going to repair this disc. Shot. Shot. Okay. Now we're going to do the entire surgery with this little tube. It's called a tubular retractor. It's a surgical tubular retractor. It's a retractor in the shape of a tube. Let's see. Sometimes the disc herniation is so inflamed it'll push the dilator out. So you got to check and make sure it hasn't moved. If your dilator comes out, you don't have any guidepost to use. Basically, you're moving blindly, and that's not a good thing in spine surgery. You always want to have reference points. Not yet. Let me have that. I think I have a little bit of tissue pinched. Shot. Just think I've cold welded it. Okay. Shot. Take. Let me have that thing. It's called the impactor. Shot. That should be good. That should be in far enough for us to do what we need to do. Yep, let's move on to the scope. So we've lost probably about 5 mils of blood, 3 mils of blood. About 60 drops so far. Not a whole lot. We may lose 5 mils the whole case. Mils are milliliters. Milliliters are 1,000th of a liter. It's a small amount of liquid. It just shows you how, relatively bloodless endoscopic surgery is compared to open surgery, where blood losses can be 500 to 1,000 or more milliliters. We're inside the disc. This is the L4-5 disc. And we're going to start by removing any loose pieces of herniation that I've pushed back into the disc. I can feel the texture of this disc, and I can feel that it's definitely damaged. It's not normal at all. And the blue stain shows you that the nuclear material is, watch the light up there, is definitely abnormal. It's been acted on by inflammation. Degenerated. We're at 30?
Yes, sir.
Thank you. Our first surgery, the cervical patient, look how nicely the laser vaporizes this stuff. That's a fresher disc herniation. See, the older disc herniations are far more scarred up, and they don't respond like this. They don't break up so easily. They stick together, and it really takes a lot of work for the laser to break up the scar tissue from the older herniations. But this part doesn't have as much collagen. What am I struggling with there? Yeah. This part doesn't have as much collagen. It's not as much scar tissue. I can still see islands of scar tissue, but for the most part, it's a little less collagenized. Collagenization is a term we use for the degree of scar tissue. Something that's more collagenized has more scar tissue. Something that's less collagenized has less scar tissue. Because scar tissue is collagen. So the degree of collagenization is the amount of really collagen, which is really a reflection of the amount of collagen that's been laid down during scar formation. More mature scars have more collagen. Earlier, younger scars have less collagen. So the degree of collagenization, more means older, less means younger. But it's not always true, because in the middle of the disc there's less of a blood supply. You don't get as much collagenization, right? Because where does the collagen come from? Anybody know? Let's see if our audience knows where the collagen in a scar tissue comes from. I'm sure there'll be some people searching on Google. But I'll give us a few minutes for people to respond. Can you hear me, Diego?
Yes, I can hear you. There is a question in the chat if you have time to answer.
Sure.
Yes. So somebody from YouTube says that they've heard of treatments in South America where they use psilocybin to cause relief in the patients in lower back pains. They want to know your opinion on that.
Yeah, so psilocybin is a psychoactive drug found in nature, produced normally by plants or fungi, in this case fungi, and people know it as the magical mushroom. Basically, psilocybin has been shown to create I can't have this loop right here like this. This is not right. Psilocybin has been shown to have psychotropic properties. What's psychotropic? It goes and works on the brain. Nobody really understands all the psychotropic activities or actions of psilocybin. I don't know. I've never heard of it being used for pain. Okay? But could it affect people's response to pain or pain pathway? Absolutely. Huh? Same as ketamine, I'm being told by my anesthesiologist. What else do you know about psilocybin with pain, with respect to pain? Like a dissociative anesthesia?
It actually resets the default mode network of pain, where your brain only knows one default mode, which is that neuro tract of pain, if you will. And things like psychedelics like psilocybin, ketamine can help the brain depart from those default mode networks and increase the production of mTOR as well as brain-derived neurotrophic factor. And those things apparently help rewiring in some sorts of the brain, helps the pathways that way.
All right, well, my partner here in the operating room, the anesthesiologist, has informed me what he understands how the mechanism of action of psilocybin and even ketamine work on the brain is that apparently they look at that, Louise.
Huh?
Look at this. We got some blurring with pressure. Maybe the lenses are starting to shift inside the scope.
And it affects neuroplasticity.
Yeah, so basically there's an old there's an old saying in neurophysiology. It's called neurons that fire together, wire together. And what it means is that neural pathways that repeatedly fire and in a sequence together generally will strengthen those pathway and relationship, because remember, neurons are not they're dynamic cells. They can actually grow connections, more connections with certain other neurons in a pathway. They can take back connections. So they're not static cells. There's not static pathways in the brain for pain. They're dynamic. They change. And so somehow psilocybin apparently, and I don't know this because I haven't done any research on it and I don't use it, but in my patients or myself, but psilocybin apparently helps pain pathway neurons reorganize structurally and physiologically so that those pain pathways that are learned over many years are abandoned for, I guess, pathways that don't allow as much pain to be perceived at the level of the consciousness. I don't know if I can explain it any better than that. I'm not an expert on that, to be quite honest with you. But good question, fair question. I'm glad you asked it because, psilocybin and psychedelics are in the news a lot these days, and they're talking about how they're used for PTSD and how they're doing research on them. I don't know how much of that is true. I can't validate that, so I'm not an expert on these type of drugs. So don't just take my opinion with a grain of salt.
I know a lot about it because I wrote the book.
Wow, you wrote the book. Nice. So Dr. Edwards has a book. What's the name of this? Let me read it out loud. Suicide, COVID-19, and Ketamine by Jonathan Edwards, MD. Hey, look it up on Amazon and Google.
So it's Suicide 2019 or COVID-19?
Suicide, COVID-19, Ketamine. The author is Dr. Jonathan Edwards. He's our anesthesiologist. Anyway, Dr. Edwards apparently has a very good understanding of the subject matter, and he's here in the operating room helping me with this patient. But I don't know. Read the book. Buy the book, read the book. That's pretty awesome. I wanted to write a book for a long time.
Okay, I found Suicide, COVID-19, and Ketamine, How a Little Known Drug May Save Lives.
There you go.
Okay.
You found it. Very good. You can put a link to it.
I sure did.
Yeah, on the broadcast. So why don't you show our audience how a annular tear that we're repairing right now, how this causes so much back pain and even leg pain. Why don't you run our animation?
Traumatic injury to the disc can cause annular tears to form. Pressure on the disc causes herniation of the nucleus pulpus through the annular tear. Inflammatory tissues develop within the annular tear, causing back pain. The inflamed annular tear generates pain signals. Additional injuries can cause symptoms to worsen. Inflammation from the annular tear can spread to nearby nerve roots, causing leg pain. Signals travel up nerves to the brain, causing localized back pain. Pain signals reach the primary somatosensory cortex, causing conscious awareness of pain. If you have a herniated
1.
Okay, we're still working on the L4-5 disc. We're almost done. We're starting to see fibers at the top at 12 o'clock there, where the laser is. Those are posterior longitudinal ligament fibers. You see how they're bigger fibers and they look different than what we've been working on, which is the annulus. This white stuff is all the annular tear. And I'm just cleaning it up, getting this blue stuff, which is the herniation, out of it. As long as the herniated nucleus pulposus sits inside the annular tear, it won't heal. And the patient will continue to have pain in their back. So my goal is to get rid of as much of this herniation as possible. Look at all this white scar tissue that's formed. These little white fluffy ruffle things is basically damaged annular tear. Just about finished here. Another minute or two. Can start to see a little fat there in the epidural space. By the way, if you've noticed since the beginning, if you've been with us since the beginning, you may have noticed how much faster it is to get the access to L4-5 rather than 5-1. Remember, it took me a while to get to L5-S1. L5-S1 is really hard to get into, and like I said before in other broadcasts, most surgeons that do endoscopic lumbar spine surgery, transforaminal surgery, they don't even try L5-S1. They just go translaminar or interlaminar, which means they're going to be removing bone and ligaments, which you really don't want. They won't even try transforaminal. The beauty of transforaminal is that you're not damaging any of the spine to get here. Every other technique damages the spine, the bones and joints and ligaments of the spine. Only this transforaminal surgery doesn't.
We have a question from Facebook. How long will the patient be in a back brace?
How long will the patient need a back brace? The answer is 6 weeks. Patients use a back brace for 6 weeks. Look at how the laser just coagulated that blood vessel. Go back and rewind and check it out. That was pretty cool. It started to bleed. There it goes again. And we just stopped it from bleeding. Laser's pretty cool, huh? I think so. All right, we're done. We're done here. Let me just go in and see if there's anything else that's going to come out. You have another question?
Yes, I have a follow-up question. They say, will the patient need any other medical equipment, like a walker?
Will the patient need any other medical equipment? The answer is no. Typically not. That's a herniation there that I shoved into the disc.
They go on to ask, will they need an adjustable bed or have to sleep downstairs?
No, the patient will not need an adjustable bed. They won't need to sleep downstairs. The patient will go home today and go into their home like they always do normally. They'll sleep in their bed normally. Everything is 100% like you do normally, except you cannot lift over 25 pounds and for 6 weeks. And you cannot be bending over picking things up from the ground. So no bending, no lifting. Otherwise, regular food, regular drink, regular shower, regular walking, everything's normal. Just the back brace and the lifting, bending restrictions, and that's it. He can even go back to work tomorrow if he wants to. This is a minimally invasive surgery, and the patients generally can go back to work the next day. They just can't do any heavy kind of construction work, you know. I say they can go back to golf, usually within 2 weeks, to putting, you know, short game. And people want to know when they can go back to swimming. You can go back to swimming in a couple of days, 3 days. Just not, you know, diving or Olympic swimming, obviously. And it depends on the activity that they want to do, but people can get back to a lot of activities. There's no deadlifting in the gym, no squatting. You got to give it at least a year to heal.
We have another question.
Sure.
So we have a patient who works in law enforcement and has been contradicting their options on whether or not they'll be cleared to perform after.
Contemplating their options?
Yes, contradicting. Sorry, they've been getting contradicting opinions on whether or not they are cleared to perform the same duties post surgery. They want to know your opinion. Would I be at more risk in instances of physical altercation after the surgery?
Yeah. Yeah, hey, thanks for asking. We have a lot of patients that do law enforcement and they do the laser surgery. Your spine will need to heal properly. It takes 1 year to completely heal the disc. The reason is because this disc doesn't have much blood supply. So because there's not a lot of blood supply, it heals slow. So you need a year before you go full duty. Now, can you go back to full duty in law enforcement? Absolutely. After 1 year. Could you do it in 9 months? Possibly. But no, we have no way to know if the disc is fully healed. There's no test that tells us when the annular tear has healed completely. There is no available test today in 2021 that I could take and do that would be reliably telling us your disc is healed all the way. So we use kind of a safe number. The safe number is 12 months. At 12 months, your disc is healed all the way. At 9 months, your disc may be healed all the way. But I don't know that for sure. But I think between 9 to 12 months is a pretty good number.
They say that they suffered a work-related injury and have recently got a L4-5 T-lift.
Okay. All right, so they've already had surgery at L4-5. You got to really ask your surgeon, because the truth is that when I do an L4-5 T-lift, I use big fat screws that are really strong rods. I use premium implants that don't break. Very rarely do they ever break. Rare. So everyone else does things differently. You may have smaller, skinnier screws that could break easier. So you really need to talk to your surgeon, because everyone thinks that a L4-5 T-lift by me, by everyone else is all the same. It's not. It's kind of like everything between a Yugo car versus a Ferrari. And the Yugo will never go, 130 miles an hour on the highway. But of course, neither should a Ferrari, right? Because you're in law enforcement. I'm just using that as an example. The point is, all these surgeons do their fusions differently. Some use cages, some don't. Some use autograft, allograft. Others use PEEK. Others use titanium. So you really got to talk to your surgeon and find out how comfortable they are putting you back to full duty. Now, a lot of doctors, surgeons will get x-rays and even a CAT scan to see, how strong the bones have healed after your fusion before they put you back to full duty. So I don't want to tell you something that your surgeon may be like, heck no, you shouldn't have listened to that Dr. Deukmedjian. He doesn't know what he's talking about because he didn't do the surgery, I did it. So that's what I would recommend. You talk to your surgeon. Okay, if I did your T-lift, could you go back to full duty? Yes, you can go back to full duty in about 6 to 9 months after a T-lift. After laser surgery, it would be 9 to 12 months. So that's only because a T-lift has got the screws and rods to help it heal faster, whereas laser surgery does not. So it takes a little bit longer. But it is all natural. Shot?
They say thank you so much.
Huh?
They said thank you so much.
Oh, you're welcome. I'm sorry I can't give you a better answer, but normally, minimum of 6 months, but, could be 9 or 12 months. And there's so many variables, like if you smoke or use nicotine or vape, that's going to slow your healing down. You may not fuse as quickly. The guy's breathing, and so I'm trying to get this dilator down the guide wire, but it's moving. It's like a moving target. Okay, now we're going to do L5-S1. So our patient is still asleep. And we're going to just nice and slow and gentle advance the dilator down to the L5-S1. And remember, I'm going past the foramen again. Yep, perfect. I'm going through the foramen into the disc. Yeah. So we're coming around the side. Shot. Beautiful. Absolutely beautiful. So we're coming around the side, and I can feel the disc. Shot. Yeah, that's nice. I'm going to bring my guide wire back just a little bit. Shot. Because I don't want it to go forward into the pelvis. And yeah, I mean, it just depends on how good of a job the surgeon did. I hate to say that, but it's so true. If the surgeon used good equipment, you know, it's kind of like, it's like me asking a police officer, how fast can you chase a criminal in a car in a high-speed chase? Well, there's no one answer, right? Because if your police force has, you know, a Ferrari squad car, you can go. But if you've got like the El Pinto, then you're only going to go about 85 miles an hour. Okay, it also depends on the suspension. It depends on the tire pressures. It depends on the chassis. It depends on your engine, you know, and the tune-up of the engine. Is the engine tuned up or not? So it's like I'm making an assumption about all the, you know, how fast can you go? 130, 110, 160. It also depends on the skill of the police officer, how good they are at driving, you know? Like some police officers are better at driving at high speed than others. So the reality is some surgeons are better than others, just like some police officers are faster drivers and some cars are better. So the reality is it depends on the equipment used, but also the skill of the operator, which happens to be the police officer, and in my case, the surgeon. That's kind of the answer. You got to think about it that way. T-lifts are not all the same. Police cars are not all the same. They're not. So that's why I recommend quality. You know, if you want to have the best chance of getting those criminals, you got to have the best equipment, the best training, and the best operator. And in spine, man, there's so many bad operators. There's so much bad equipment out there. And you think it's all standardized, but it's not. It should be standardized. That's why we show these videos. Because it should be standardized. You know what I'm talking about. If someone's holding up a bank, you want SWAT there. Why? Because SWAT has better equipment, better training. You know? You don't get the guy that writes parking tickets all day to go take out, you know, bank robbing criminals that have AR-15s and full body armor. You need a equal kind of, you know, equal situation on your side so you have a chance. All right. Any other questions?
Yes, we have a viewer who's been watching our videos for a long time, and they recently saw that you've done carpal tunnel streams. They
Yeah.
want to know, do you do any other non-related surgeries, like besides spine?
Yeah, great. You're right. I'm a neurosurgeon. I forgot. Neurosurgeons do lots and lots of surgeries. We are very well trained at doing brain surgery, nerve surgery, spine surgery, kids' brain tumors, hydrocephalus, aneurysms, AVMs. I mean, I kind of downplay my experience and ability when it comes to anything but spine. But the truth is that I could probably stand with some of the best of them, technically, because I went to the best training program, one of the best in the country. So I don't do a lot of other things like carpal tunnels, ulnar nerves, brain tumors, but I have done them many times in the past. So I'm very good at it. I also did a fellowship in epilepsy surgery, so I can actually do epilepsy surgery. I can do an anterior temporal lobectomy, I can do a corticectomy, I can do a lot of things that I don't do and I don't broadcast. But it comes back to what I said earlier, which is, you know, doctors should really focus on what they're really good at and what sets them apart, and focus on those services for patients, and let other doctors that focus on the other things, you know, do those other treatments. I'm really, really good at spine. I'm also really good at brain, but it's too much to do, and I'd have to be in the hospital all day, you know, taking care of the brain patients. And the truth is if I'm in the hospital all day taking care of the brain patients, I can't do spine surgery. So you have to give up, you know, in your career, you have to give up certain treatments and things you do in order to do others. So I can do a lot of things neurosurgical, but I limit my practice because I'm so busy with the spines, fixing back and neck and thoracic pain, that I just focus on those. I don't know if that's a good answer, but that's the truth. And, you know, I don't miss doing brain surgery that much, because a lot of the patients that get brain surgery, they don't do so well. And it doesn't matter who does it. They just have a really bad disease. What's that noise? It's a suction.
Yeah,
Is it me?
yeah.
Huh?
Yeah,
Okay. Thought maybe I was passing gas. I'm like, wow. I did have Mexican for lunch, but that is quick. All right. So anyway, what I was saying is that yes, I'm capable of doing a lot of things in spine, but I mean in neurosurgery, but I really focus on spine. That's where honestly the greatest need is for my skills and services, because there's so many neurosurgeons that, you know, they do brain tumor surgery, they do aneurysm surgery, they do endovascular neurosurgery, they do pediatric neurosurgery and epilepsy surgery. Basically, there's plenty of surgeons that treat all those conditions, but there aren't many that fix pain. It's because they all think pain is a joke, and I've heard them say that. It's sad. When I told my mentor that I want to take care of patients in pain, I distinctly remember as a medical student telling him that. And he said, "What?" I mean, literally, like, what? Wait a second. Wait, you're going to be an aneurysm surgeon. You're going to be like a famous aneurysm surgeon. And I'm like, okay. I wasn't going to argue with him. I just figured I was wrong. You know, I needed to straighten out my priorities. And then I went in, and of course I trained to be a famous aneurysm and brain surgeon, but I went to the best program in the country. And when I got there, I started gravitating, after a few years, I started gravitating to spine conditions, because my attending there, Dr. Jeff Henn, who was a real inspiration to me, Dr. Henn trained at the Barrow Neurological, which is the top spine training program in the country for neurosurgery spine. He trained with Volkner Sontag, Curtis Dickman, a few other guys out there who are really, really top spine surgeons. And they were pioneering spine surgery. At the time, this was back in the 90s, late 90s, early 2000s. It was all about, you know, metal fusions and artificial discs. So we were doing the most advanced spine surgeries in the world, you know, complex reconstructive surgeries and stabilization with instrumentation and fusion. And I was learning all that. And it was great, because a lot of the other residents just wanted to do aneurysms and tumors. And I'm like, brain tumors. I'm like, well, I'll do the spines. And I started to see these patients that had these amazing surgeries, and they were doing better. They were like getting well. They were leaving the hospital the next day. You know, compared to an aneurysm surgery patient that stays there for weeks and is really on the edge of life or death every day. And a lot of them get complications like meningitis and hydrocephalus and strokes, and then they have to be discharged to rehab. And you know, there's an important need for doctors to treat those patients, but for me, I just kept going back to pain. I was like naturally drawn to fixing pain. So I know Dr. Weiss, I don't think he's alive anymore, but you know, maybe he'd be disappointed with me for not doing something sexy like aneurysm surgery. But I still can do aneurysm surgery. I can clip an aneurysm tomorrow. I could do it probably very well. But I can't do it here at Duke Spine Institute because we don't have the resources. We don't have the equipment. I mean, that you're talking about expensive equipment for managing patients with subarachnoid hemorrhage from a ruptured aneurysm. You're talking about even more money than what I've spent on all of this equipment for the laser surgeries. I spent millions, but to run a neurosurgical ICU and a neurosurgical OR to do aneurysm surgery, you're talking about tens of millions of dollars in equipment and staff and, you know, training. So yes, I can do lots of other procedures, pretty much anything neurosurgical, and I just don't do it because I'm so busy with fixing people's back and neck pain. I don't know, maybe that was too long of an answer. We're just about done. About 1 minute. Huh? I don't think you need to. We're done. That's all right. We're done. Don't be a Karen. I'm kidding, you know that. I'm kidding with you. You're like, I'm not a Karen. I'm a Crystal. All right. Any other questions for me?
Yes, one more question. What's
Yes.
the longest amount of time you spent on one surgery?
The longest amount of time I spent on one surgery. I talk about this every once in a while, right? I think my team knows the answer. 17 hours, and that was a brain tumor at the VA hospital in Gainesville for the veteran on a vet. Scope off. It was an acoustic neuroma, called an acoustic neuroma, which is a tumor that grows off of up by the nerves going to the ear, inside the skull. And that was a 17-hour surgery. And the reason it was 17 hours is that the surgeon I was doing this surgery with, his name is Dr. Roper. He's an attending. I have a lot of respect for Dr. Roper. I love Dr. Roper, but he's the slowest neurosurgeon on the face of the earth. And he literally takes tumors out one cell at a time. And if anybody was going to do my tumor, he would be the one. He was actually my mentor when I did my NIH research, NIH-funded research. I'm just disappointed in myself, that's all, for letting that fall. Dr. Roper had a nickname when I started, so it was pretty funny. Dr. Roper trained at UCLA. He's an epilepsy surgeon. And Dr. Roper is a skinny guy who plays the electric guitar. He's all amped out. And when I started neurosurgery training at UF in Gainesville, the chief resident every day assigns, he or she is the 7th year resident, they assign the residents to every operating room. So if there's 6 ORs going with six attendings and cases, they pick who goes in what room. And the junior resident, the lowest person on the totem pole, you know, the lowest filth of a doctor in our neurosurgery program, was put into Dr. Roper's room. because nobody wanted to be in there. And the moment you had some seniority in the program, once you became a second level junior, then you were not going in there anymore because nobody wanted to operate with Roper. And Roper would sit there the whole case and just like bury his face in, and just under the microscope or there, he'd just be operating like this. And you're like trying to see what the hell he's doing, and you can't see past his head because he's got his whole face in a wound. So you're not learning anything watching. He doesn't let you do anything. You're not even allowed to do anything except irrigate. And so irrigate, and then you graduate from irrigate into sucking with a sucker. And so he had a nickname. His nickname was Dr. Jekyll and Mr. Hyde. And he had a reason for that nickname. Is because he would be the calmest, quietest, nicest guy 1 minute, and he would literally on a needle tip pivot to like the most, like a badger, a honey badger just going wild. All right? So he'd be like sitting there, we always make fun of him, he'd be sitting there talking about Led Zeppelin. He'd be like, yeah man, and then Led Zeppelin came out on the stage, what the fuck are you doing? Suck! Suck! You know? Just like that. And then I'm like, okay, I'm sucking. And they'd be like, oh yeah, and then they came out on stage and they were like ripping it up with that riff, and you know, everybody was going crazy. So Dr. Jekyll, Mr. Hyde, Dr. Roper, he turned out to be my mentor. I picked him as my mentor. But I'll tell you, he really makes you pay attention to the details. All right, we're done. Everything went good. I think he's going to do fantastic. We had no complications. Our blood loss, I'll call it 5 mil. And this was the left side. Everybody agree? DLDR, L4-5, L5-S1. All right, type up your questions for me, and I will come and answer them for you. Good job, everyone. 2 more to go. The next one's a bilateral 3-4-4-5 lumbar for 2 herniated discs on both sides with leg pain down his legs. Dr. Ara Deukmedjian with the Deuk Spine Institute and another edition of Spine Scams Exposed. So we're going to be talking about a very common topic we talk a lot about because there's a lot of scams associated with it, and that is artificial discs in the spine. Now artificial discs are basically small, chasing it around. Yeah, but it's your job to get it right. That's what I'm trying to say. Now I can guide you, but ultimately I got to worry about what I'm doing. You've got to get me the right picture. So I don't think that's too, again, you just swung down south. You're showing me too much sacrum, not enough of 4. What happens when you get too much hip? Huh? No, you get too much hip, you use too much X-ray radiation. You have to boost to get through all that soft tissue and hips. So you really should be, that 5-1 disc should be in the bottom half of the screen. I shouldn't be wasting 10 minutes trying to. That's exactly where it should be. Now you just got to get the pedicles lined up and the end plates lined up. And that actually this because there are so many people out there having problems with them that you need to know about these problems, and that's why we cover it from time to time. We've got a whole series now on artificial discs as spine scams. So why do people get artificial discs put in? They get artificial discs put in for one reason: they're in pain. Okay, they're either having neck pain or lower back pain, and these artificial discs can be put in through the front in the neck or through the front in the lower back. The key is they have to go through the front, and that in itself brings about problems because going through the front of your belly can create all kinds of complications. We're going to talk about some of those complications today. But I'm also going to highlight some of the viewers on Facebook who have been posting about their artificial disc experiences so you can learn from their mistakes. So let's take a look at this first post on Facebook under the cervical disc replacement surgery group. So here's a patient who says, I'm 1 year post-op from a C5-6 anterior disc replacement right through my neck. And the last few weeks have been the most intense muscle tension and pain in my neck, shoulders, and upper back. It's causing problems in my jaw, headaches, almost daily, and inability to sleep. So here's a patient who went in with one bad disc in their neck. They could have had the Deuk laser disc repair, and that's one of the reasons we want to bring this to your attention. You have all this pressure, all this financial pressure from companies that want to put those discs in you so they can make money. And that's driving surgeons to implant these artificial discs that don't work well at all. While on the other hand, there's a new technology using endoscopic surgery, tiny 4mm incision. We go in with a tiny tube and we actually repair your own disc. We don't put anything unnatural in your body. There's no metal or plastic. There's no company getting fat and rich off of your surgery. It's all about you and doing what's best for you. The problem is most surgeons don't know about this surgery, and they don't know about it because they're not being puppet controlled by the big companies to do the endoscopic surgery. You see, there has to be a motivating force behind it. For us at Deuk Spine Institute, the motivating force is to do what's best for the patient, least invasive, most successful treatment. And that's the Deuk laser disc repair endoscopic surgery. I brought the technology over from South Korea, and I brought it to the United States, and it works amazing. We've done over 1,000 surgeries now on patients in the last 15 years with basically 98% elimination of neck pain and arm symptoms and even headaches associated with artificial discs. Now this poor patient here is suffering with pain in their shoulders. They've tried massage, they've tried the tennis ball, they've even had muscle relaxers which cause their heart rate to drop into the 40s. That's not good. So basically they could have a heart attack from the medication they're used to treat the pain they're having as a result of the artificial disc surgery. Mind you, this is one disc that was repaired. All right, so now they have an appointment to see their primary care doctor. Basically, the surgeon that put the disc in is of no help to them, useless. So they have to go back to their primary care doctor. That's the wrong doctor to help you with a spine problem. You need your spine surgeon helping you, but they've abandoned this patient. Here this patient says, I've spent thousands of dollars on taking care of medical problems that are related to complications from my artificial disc. Okay, I'm live. Hey, I am alive. Dr. Deukmedjian here. We just finished up a surgery on a patient who had 2 disc herniations, which we showed you at the beginning of this reel. If you want to rewind. Right, Diego? Reel, huh? Did you ever work with reels?
A couple times.
Couple of times. So movies were always shot, production, reels. It was done on film, 9mm, right? A long time ago. And now everything's digital. So Diego's just like a digital baby. He's never really worked with a reel. But so basically, if you want to rewind digitally, you can go back to the beginning and see that this patient had an MRI. And that MRI, we kind of showed you a side view at the beginning, and it showed 2 herniated discs, one at L4-5, one at L5-S1. Yeah, there it is right there. Diego's pulled it up behind me. Nice job, Diego. Well, there they are. You can tell those discs are different looking than the ones above. And they're bulging out there in the back. And that's where his pain was coming from, what's called an annular tear at L4-5 and L5-S1. So let me show you what that annular tear and disc herniation kind of look like. If you look through here, okay, this little model, you see that tear back there. And then whenever people kind of bend forward or lift something, they put pressure on their spine and the jelly squeezes out. You see that? Isn't that cool? You like that model? I designed this model. This was made for me by a Canadian. He's actually a chiropractor, but this particular model I designed. And what it does is it shows you through the bone, which is hard to see, but you can see the tears in the back there. They're red, and there's these little yellow things where the nerves are along the tear. And that explains why there's back pain. And so I designed this model, and he created it for me so I could teach all of you about it. I've had these sitting in my office now for years. So I just don't use them very much. But you can see the jelly coming out there and then back in. So anytime people bend forward, they're putting pressure on the disc, and that actually squeezes more disc material out through the tear. So this patient has tears in the annulus, and the jelly is pushed through the tear, wedged in there, and that was causing all of his back pain. We tested those discs with what's called a discogram, and the discogram showed that one disc was a 10 out of 10, the other one was an 8 out of 10. So that's the result we got, and that was his typical pain. I said, is that where you typically get your pain? He said, yes. So that pain will be gone now that we did the Deuk laser disc repair. All right, we did it all through a 7mm incision, and we lost 5 milliliters of blood, which is about 100 drops of blood. We're going to take questions right now. By the way, in case you didn't know, we have a new segment on our YouTube channel. We call it Spine Scams Exposed. There it is. Nice. And Spine Scams Exposed, we talk about all kinds of crooked behavior in the spine world, and I expose it along with Diego. Diego is like amazing. So he's made my boring videos much more interesting because he adds a lot of good content to help people understand what I'm talking about, because I just talk sometimes in a different language, the language of spine surgeons, but to really relate it to people so they understand what we're talking about, Diego comes in and does some really good editing. Long story short, Spine Scams Exposed, good entertaining content, better than anything on Netflix. And we also have our Deuk Spine Institute app, which is downloadable for free on your phone. And you can go through the app, and there's a lot to learn in there. We have good stuff, pictures and content and videos. We also have the Facebook Spine Surgery Support Group. Free to join. We just don't like trolls. And you know who you are, trolls. You're a very negative person. Don't come to our site and leave us alone. We are there to share factual information with people, to openly discuss things, and we don't like trolls. So if you're a troll, don't even bother. Just abstain. We don't want to see you in the site. I'll boot you. And then what else do we want to talk about? The YouTube channel. So the Deuk Spine Institute YouTube channel. Check it out. We got a lot of content. We add things every week, almost every day. We have thousands of videos now under Deuk Spine Institute umbrella, all educational. Okay, what's our first question?
All right, well, first we have a patient from the UK where lasers not an option, and they had a microdiscectomy on L4-5 and L5-S1. But both of those discs have herniated. Listen, he's asking for your advice. Should he repeat a microdiscectomy?
Absolutely not. Oh, you don't want a TLIF either. You don't want either. So we've got a viewer who, you know, I'm going to show you this model right here so you can understand it. Sorry.
Someone commented, like, he better have lots of cash.
Yeah, you better have lots of cash, right? So basically, bone, disc. And right here, there's a herniation. You see that? So the front of the spine is there. This is the front. The back of the spine is here. There's the back. And a microdiscectomy, and by the way, we got great news. We're releasing a video. It was just finalized today. We're adding the voiceover and the banner for the microdiscectomy laminectomy on it. We're going to release that on our YouTube channel probably this weekend. So you're going to be able to see our first Deuk Spine Institute YouTube video of microdiscectomy laminectomy. And it's going to present it in a completely different light. It's going to show you what really happens. Because the doctors that do microdiscectomy laminectomy, these are old-fashioned procedures. They're horribly destructive to your spine. They're going to damage all these bones in here and ligaments, and you're going to see firsthand in our video exactly what I'm talking about. Well, you have experienced it firsthand. You had a dual microdiscectomy laminectomy, you're reherniated, now you're back in the same boat, maybe worse than you were before. Horrible procedure. Stay away from microdiscectomy laminectomy. It's what most surgeons are going to offer you, only because they don't know how to do what we just did today, endoscopic spine surgery. Hey, if you can't keep up with the latest and the best treatments for patients, get the fuck off the boat. You know what I'm saying? Why are you trying to do things to people that are damaging to their spines and their lives? leave, refer them to a doctor that can do the latest treatment. I wasn't born with an endoscope in my hand, like, wah, I know how to do endoscopic spine surgery. I had to go out and learn it. I learned a lot of different surgeries. As a matter of fact, I've learned all different surgeries. And now I've got 500 different types of spine surgery that I can do. And guess what I do? I do the best. The best is the laser surgery, the endoscopic Deuk laser disc repair. So doctors that don't bother to take the time to go out and learn the best technology for you, the patient, instead they rather work on their golf swing, or maybe they rather go on vacation or fly their jet around, whatever. They don't have your best interest at heart. And if you want to treat with them, hey, by all means, it's a free country, free world, go treat with them. But if you want the best, then you better be looking at endoscopic spine surgery, because that is the best. All right, endoscopic surgery, instead of going through the bones and ligaments and drilling them away, we go around. I go around. I come from the side. Can't even see my toothpick. But I go around and under the nerve root. There's the nerve root. So I come from the side and I get into the herniation and I remove it with the laser. And I clean up the tear. Okay? All these other doctors that do microdiscectomy, they're peeling your muscles off your spine. Literally ripping them off. I've seen them rip them off. They rip them off. And they're destroying your muscles. So if you look at an MRI a year later, you're going to see all the scar tissue where your muscle's dead. And then they drill holes in your bone. Okay, bad. That's bad. It's going to weaken your spine. And then they're going to peel your ligament out of there. The ligament that connects one bone to the other and stabilizes it, but they peel it out. Not only do they destroy your facet joint, they're peeling your ligament out. And then, oh, maybe we can see the herniation now. And they go and try and pull out little pieces of it. It's a shit surgery. That's why you reherniated. Don't do it. Don't do the fusion. Get yourself out here to the United States. Get the laser surgery. It's worth it. It's your spine. If you want to continue to have problems from surgeries that are inferior or suboptimal for you, that's what you're setting yourself up to. You know, folks, that's why we do these broadcasts. We do these broadcasts for one reason. If I didn't have a better surgery for you, we wouldn't bother doing the broadcast. If all I did was fusions, which I've done many, or microdiscectomies, we wouldn't be broadcasting because there's nothing to teach you because you're already getting it. Maybe we do it better, but that's not worth broadcasting for. So we're trying to tell you there's a far better surgery out there, endoscopic, transforaminal in the back surgery. And in the neck, it's through the front, transdiscal. Okay, educate yourself, understand what's best for your body. I would not have another microdiscectomy. I would not have a fusion, okay? Travel and get what's best. If I want to see Big Ben, I don't go onto my virtual reality, headset. I don't go on the computer. I travel to England. If I want to see the crown jewels, I travel to England. You understand? If I want to have haggis, I go to Scotland. If I want to watch a Formula One race, I go to the Formula One race, wherever it is. Of course, I've never been to a Formula One race, but I would like to someday. The point is you go there and experience it the right way. Go and get your back or neck fixed properly. Invest the money and time into your body, your health, and then you can enjoy yourself the rest of your life knowing you did it right and you don't have any more pain or complications.
Patient says he works a physical job, a lot of bending and lifting, and he just recently submitted his MRI to your website and looked, so we can take a look at his reherniation.
All right, well, I will be happy to look at your MRI and anybody's MRI of their spine, and we will give you my thoughts, my opinions. And by the way, for those of you who take advantage of the Deuk Spine Institute free MRI review, you know that it's me. I'm the one talking to you on the video camera. And I sit there and I go over your MRI with you. Yeah, we only get 15 minutes, but hey, you're not paying for it. You're getting basically a $1,000 consultation for free. And so take advantage of it. Honestly, I don't care if you come here and treat or not. As long as I've done my job of telling you what's wrong with your back or neck, you decide what you want to do. It's your choice. You're all grown-ups. But at least you had the opportunity to do what's right for yourself.
That's it.
Thank you.